Hey guys, I'm Dr. Trevor. So we are going to talk about some basic medical concepts working in low middle income countries. So today we are going to talk about the vital signs and emergency science. So these slides are mainly based on cellular Plans National Training Manual, Oxford Handbook of Tropical Medicine, and MSF. So which one is the vital signs? A. Body temperature. B. Heart rate. C. Respiratory rate. D. Blood pressure. E. All of the above. Yes, so the answer is all of the above. So body temperature, heart rate, respiratory rate, and blood pressure, they are all vital signs. So first, we're going to talk about the body temperature. So we can measure by using the thermometer on the armpit and under the armpit for 1 minute. So you have to listen to the beep sound to make sure that the measurement of the body temperature is finished. So what is the normal range for body temperature? Is 36 degrees Celsius to 38 to below 38 degrees Celsius. So whenever the patient feels cold and hot to touch, you need to check and record the body temperature. Because if the body temperature is higher than 38 degrees Celsius equals to 38 degrees Celsius, the patient is having fever. But in children with severe malnutrition, sometimes the temperature might be lower than 36 degrees Celsius, which is hypothermia. It can also be a sign of infection. So what are the common causes of persistent fever? Let's say the patient has received treatment of antibiotic for a few days, but the patient is still having fever. So why is that? So there are 5 things we need to consider. The first thing is the diagnosis. Is the diagnosis correct? Have we test for the RBS test? Maybe the patient is having tuberculosis. Maybe the diagnosis is not correct. And we need to find the other diagnosis. And secondly is drugs. So are drugs given every sign in the blood chart? And was it the correct drugs given? And the thirdly is the dose. Is it given by the body weight? Is it underdose? And the fourth is the duration. So are the drugs given at the correct time? The lastly is the drainage of the problem. So let's say the patient is having deep-seated abscess. So the antibiotic will not work if the abscess is not drained. So sometimes it's very important to perform incision and drainage for very severe and serious abscess. So the second vital sign is heart rate. So let's say the 4-year-old girl is said to be reward with a heart rate of 150 beats per minute. Is she having tachycardia? So for this question, we need to check the normal pulse rate in children. So for 0 to 1 year, the normal pulse rate 100 to 160. 1 to 3 years is 90 to 150. 3 to 6 years, 80 to 140. So for adults, the pulse rates are 60 to 100. So let's go back to the question. 2 years old girl was sent to the hospital with heart rate of 160. Actually, having tachycardia. So as you can see, 2 years old, like between 1 to 3 years old, and the number should be 90 to 150. So if the pulse rate is 160 as mentioned in the question, so she's having tachycardia. Now the next question is, what are the common causes of tachycardia in the hospital? So to answer this question, we have A, B, C, D, E, F, G, H. A stands for airway, and the patient is having hypoxemia. B is breathing difficulty. So there are signs of respiratory distress. We're going to talk about it later. And then C is circulation, which means the patient is having a shock. We will also talk about it later. And D is drugs. So some of the drugs like salbutamol, like theophylline, will increase the heart rate, which causes tachycardia. So E is epirocyte anemia, and F is fever. G is glucose. Let's say the patient is having hypoglycemia, low blood glucose. So he or she might also have tachycardia. And then H stands for hurts, especially when the patient is experiencing pain, anxiety, and crying, especially in children's ward. They will also have increased heart rate. So let's talk about the respiratory rate. So same question. Let's say a 2 months ago is sent to people with the respiratory rate of 60. Is she breathing fastly? So to answer this question, we also need to know the normal range of respiratory rate in children. So we need to count the respiratory rate for 1 minute when the patient is calm. So if the patient is less than 2 months old, the normal respiratory rate should be less than and equals to 60 breaths. 2 to 11 months, less than and equals to 50. 1 to 5 years old, less than and equals to 40 breaths. If the patient is more than 5 years old, the respiratory rate should be lower and equals to 30. For adults, it should be less than or equals to 20 breaths. So let's go back to the question. If the 2 months ago, with respiratory rate of 60, so 2 months to 11 months should be less than or equals to 50. So the question was 60 breaths, which means the patient is breathing fast. But sometimes it's not just about the respiratory rate. We are also very concerned about whether there's any signs of respiratory distress. So the signs of respiratory distress are fast breathing, excessive flaring, head nodding, rapid tap, chest injury, and deep acidotic when breathing. So let's start from the head. So sometimes when the patient is having respiratory distress, you will see the head is nodding during the respiration. And then after the head is the nasal flaring. So you will see the nose is vibrating. And then let's go down to the lips. You will see the lips will turn blue and purplish, which is called central cyanosis. And then after that, let's go down to the chest. You will see retraction over the tracheal area, which is tracheata, intercostal retraction, and subcostal retraction. So the last vital signs is blood pressure. Now, why is blood pressure so important? So when the pressure is too low, too little blood carrying glucose and oxygen to our important organs like heart, brain, and kidneys. And because there are too little of blood and oxygen, it will cause the organ damage. So for the heart, it will reduce the heart pumping and the contraction function. The brain, the patient will present with lethargy, irritability, coma, and convulsion. And for the kidneys, it will stop releasing urine, so the urine output will be decreased. So when the patient is having shock, you will see that the urine is less. And then shock is often accompanied by hypotension, which is low blood pressure. The definition of hypertension in adults. So hypertension is mainly based on SPP, systolic blood pressure in adults. So when the SPP is less than 10 mmHg, the patient might have shock. But let's say the patient is having hypertension, high blood pressure at the baseline at home. So if there's a decrease in systolic blood pressure higher, more than or equals to 40 mmHg compared to the baseline, the patient is also having shock. And then the last criteria is the mean arterial pressure less than 65 mmHg. But the only thing you need to remember is if the systolic blood pressure less than 90 mmHg, the patient might have shock. But how about children? We know that the cuff for the beeping machine might be too big, too large for the children, and it's hard to measure blood pressure in children. So the definition of shock in children is core extremity or peripheries, and capillary refilling time longer than 3 seconds, and you can fast pulse. So you must fulfill all 3 signs to be in shock. If only 1 or 2 features are present, the child has impaired circulation but is not in shock. So how do we detect shock? By looking at the patient whether the patient is having lethargy, reduced level of consciousness using the ABPU scale, and we'll talk about it later. Are there any signs of dehydration? How is the skin turgor, the skin pinch? Are there any signs of severe pallor? You look at the conjunctiva and any cyanosis. And then you listen to the heartbeat and feel the hands and feet, whether it's cold or warm. And then we also check the pulse, whether the pulse is weak or strong. And the last thing we need to do is measure the capillary refilling time. Is it longer than 3 seconds? So there are different types of shock. So the most common type is hypovolemia, when the patient is having severe dehydration, severe anemia, and severe hemorrhage, severe bleeding. And then the second type of shock is distributive shock, which is the blood vessel dilate, which is vasodilatation. So this happens when the patient is having severe infection, sepsis, and anaphylaxis. And the third type of shock is cardiogenic shock, like the patient is having chest pain, ischemic heart disease, and acute heart failure when the heart couldn't pump out the blood to our body. So this is cardiogenic shock. And then the last one is obstructive shock, when the patient is having tension in muscles and pulmonary embolism. So these are the common causes of shock: severe dehydration, severe bleeding, severe infection, severe anemia, and severe allergic reaction. So that's why we always check vital signs every 30 minutes during blood transfusion, because the patient might experience transfusion reaction, which is a type of anaphylactic shock. So why is this so important? Is because of the management. So the problem with management of shock in children depends on whether the patient is malnutrition or not. So in pediatric ward, it's important to screen any patients whether he or she has malnutrition. Because if the patient is not having malnutrition but having shock, we can transfuse whole blood with 20 ml per kilogram over 4 hours if hemoglobin is less than 5 grams per deciliter. For patients with no malnutrition, and after the blood transfusion, if he is still having shock, we can consider fluid resuscitation with ringer-selected or amoxicillin of 10 ml per kilogram over 30 minutes. However, if the patient is having malnutrition, and shock at the same time, so we can only transfuse whole blood of 10 ml per kilogram over 4 hours, because when the patient is having malnutrition, the heart function is poor, and if you transfuse too much blood, it will cause pulmonary edema, and the patients will experience shortness of breath. So in patients with malnutrition and shock, if they need blood transfusion, we give less blood transfusion compared to the patients who do not have malnutrition. So after the blood transfusion, if he or she is still having shock, so we can transfuse previous lactate or normal saline with 5% of dextrose of 15 ml per kilogram over 1 hour. So we give slowly and with sugar is because it's very common for children with malnutrition to have hypoglycemia. So after the blood transfusion and fluid resuscitation, you can consider Rizoma. So Rizoma is rehydration solution for malnutrition. And we'll talk about it later. And we'll also talk about how to calculate the drop rates in the future lecture. So the second part is we're going to talk about the pediatric triangles and emergency signs. So in adults, we can always ask the patients, how are you? How do you feel today? But we know that some of the children, they couldn't express themselves very well. How could we tell whether the patient is doing fine or not? So there's a concept, it's what we call pediatric triangle. So first, we can look at the appearance. A stands for appearance. And then we can monitor the muscle tone, whether it's normal muscle tone or it's very floppy, which means the muscle tone is very weak. And then we can also observe whether the patients can interact with the others. And when the patients cry, is it easy to console, to calm down? And we can also see whether there's any abnormal look, abnormal gaze, speech, and cry. So this will be very obvious when the patient is having severe malaria. Because when they came in with severe malaria, they usually looks very weak and they don't interact with the others. And sometimes it's very hard to calm them down. But after a few days of treatment, you see the muscle tone and the interactiveness will improve very fast. And then the second element of pediatric triangle is breathing, the work of breathing, as we mentioned about. There are signs of respiratory distress, head nodding, nasal flaring, and down to the lips, cyanosis, down to the chest, tracheotomy, intercostal retraction, and subcostal retraction. And then the last element of pediatric triangle is circulation. So we mentioned about the definition of shock, which is core extremities, keeping the time longer than 3 seconds, and we can fast pause. So we can also observe if there's any pallor. You can look at the conjunctiva, look at the palms and the feet. And then the last thing is when the patient is having shock or poor circulation, we see some skin rash, bluish skin rash over the extremities, which is called mottling. So we used to say there's an emergency case when a new patient comes, but it's important to evaluate whether the patient is having any signs of emergency signs. So the order of emergency signs is A, B, C, 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 D, D, D. So A stands for airway, whether the airway is obstructed or absent breathing. So B are the signs of respiratory distress. And also, actually, it's very important for us to measure the SpO2 for the saturation. So if the saturation is lower than 19%, it's also one of the emergency signs. And then C, circulation, stands for the shock. So C is circulation, core extremities, with refilling time, and also we can pass. And then for the DDD, the first D is the dehydration, severe dehydration in diarrhea. So is severe dehydration stands for diarrhea plus two of the following. So the first one is lethargy, and then the second is sunken eyes. The third one is very slow skin pitch, more than 2 seconds, and then unable to drink or drink fully. And then the second D is the disability, which is coma. The ABPU scale equals to pain or unresponsive. And then also convulsion, which is happening at the moment. If the patient was having convulsion at home, it is not considered as an emergency signs. And then lastly, stands for death. So if the patient is having AB, CCC, UDD, or any of these emergency signs, you must call a doctor directly. So these are all the take-home message. So we need to check body temperature when the patient feels or hot to touch. And then we need to consider about the causes of persistent fever. Is the diagnosis correct? Are the drugs given? Is the dose correct by the body weight? And was it given at the time? Is it the correct duration? And do we need to consider drainage or debridement for the abscess? And the normal range for the pulse? And also the causes of tachycardia. A, B, C, D, E, F, G. For the respiratory rate, we need to know, we need to memorize the normal range. So the signs of respiratory distress. So for the blood pressure, we need to remember that hypertension is mainly based on systolic blood pressure in adults, which is less than 90 mmHg. The definition of shock in children with all of these three criteria. And then the pediatric triangle, ABC, appearance, breathing, circulation. And then the last one is the emergency signs, AB, CCC, UDD. These are the supplements you can read. Thank you.